Hello, everyone, and welcome to the Guthy-Jackson Charitable Foundation NMOSD Grand Rounds. We welcome all of you who are attending today, and we'd like to remind you that the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendation or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The overarching goals of NMOSD Grand Rounds are to offer a practical summary of the latest information on a specific topic. The series is designed to emphasize key themes and clinical pearls. It is also intentionally inclusive of non-specialist audiences. And importantly, at the conclusion of the presentation is a pocket guide that synthesizes much of the information that will be presented during the presentation. Please note that this presentation and all of the presentations in this series are eligible for continuing medical education credit. The process for CME credit is summarized here and can be accessed using the QR code you see on the right side of the screen. To do so, please visit the Guthy-Jackson Charitable Foundation Education Center, select the session you're interested in, and register for that session. View the session and fulfill the CME requirements and receive CME certification. My name is Dr. Michael Yeaman, and I'm an advisor for the Guthy-Jackson Charitable Foundation. It's my pleasure to introduce today Dr. Jeffrey Bennett. Dr. Bennett is a world expert in NMOSD, and in particular in the topic that he'll address today, which is therapeutic decision-making, rationale, and transition. Jeff, thank you so much for being here today, and we really look forward to your presentation. Thank you.
Well, thank you, Michael. I'd like to first thank the Guthy-Jackson Charitable Foundation for inviting me to give this talk on therapeutic decision-making, rationale, and transition in neuromyelitis optica spectrum disorders. These are my disclosures. None of these entities had any role in the development or presentation content that's described here. Neuromyelitis optica spectrum disorder is a recurrent inflammatory disorder of the central nervous system, predominantly characterized by attacks of optic neuritis and transverse myelitis. There are smaller frequency attack presentations, including diencephalic syndromes, brainstem syndromes, area postrema syndrome, that is protracted nausea, vomiting, and cerebral syndromes. Roughly 90% of patients with this disorder have pathogenic autoantibodies against the aquaporin-4 water channel, which is found exclusively on central nervous system astrocytes. The histopathology of the neuromyelitis optica lesion shows evidence of antibody-mediated effector functions with C9 neocomplement deposition in the lesion, as well as antibody deposition, both IgM and IgG, and there is evidence of polymorphonuclear and lymphocytic inflammatory cell recruitment, astrocyte destruction, and myelinolysis. You're going to hear more about this in future lectures in this CME series. However, what I want to concentrate on today is the treatment of NMOSD, and to cover three important questions. Why do we want to treat patients with neuromyelitis optica spectrum disease? To take a very focused and brief look at what drives NMO immunopathology so you can understand the therapeutics that have been developed in the field, and to concentrate on both the current and future therapeutics in terms of how they might address lessening lesional injury in acute attacks and how they might prevent relapses in patients who have this condition. And we're going to look at both what are currently approved therapies and where we might be going in the future. First, let's deal with why do we treat NMOSD? And I think the natural history of NMOSD can clearly illustrate that without treatment, there is a high probability of significant and permanent neurologic disability. As seen on the left here, and we're going to concentrate on the dotted lines, which represent the seropositive patients for which therapies are currently approved. At 5 years, roughly 1/5 of aquaporin 4 IgG seropositive NMOSD patients are expected to need ambulatory assistance, mostly due to transverse myelitis, brainstem, and cerebral attacks. On the flip side, as shown on the right, without treatment, after 5 years, almost half of neuromyelitis optica spectrum disorder patients are legally blind within one eye, and up to 10% could be blind in both eyes. Obviously, without treatment, there's a pressing need to prevent neurologic disability, and therefore engaging in treatment as soon as possible is important. But also I want to emphasize that there's a pressing need to treat acute attacks as quickly as possible. As can be seen just by the mention in the center of this slide, the median disability change, in contrast in an attack of MS, is pretty much 0, whereas the median change in an NMOSD attack is almost 1 point of drop in neurologic function. And if you look at what state of NMOSD patients in terms of neurologic disability is contributed by that very first attack, those that need ambulatory assistance with an EDSS of 6, about 25% of that disability is contributed by the first attack. And it's even worse when we look at visual function, where blindness can be contributed by the first attack in upwards 40% of patients. And in the top graph, I want you to look from left to right to appreciate that the timing of relapse treatment is incredibly important. For those treated within 3 or 4 to 7 days, there is much greater probability of remaining stable, as the arrows indicate, with regard to neurologic function. However, the longer the duration that proceeds between the initiation of the attack and institution of treatment, the higher likelihood that the final disability is going to be greater than when patients started. So now that we know that we need to treat this condition, let's look at what data we have to drive the direction of this treatment. We understand that aquaporin 4 IgG, drives NMOSD lesional injury. In animal models, we've been incredibly successful at reproducing central nervous system lesional injury in animals. Whether we take slices that are placed in a dish, whether we open up the blood-brain barrier with inflammatory cells, whether we inject antibody directly into the brain with complement, or we look at animals that have been passively transferred aquaporin 4 IgG, we can show that aquaporin 4 IgG in the presence of human complement drives all factors of what is lesional injury. And this means polymorphonuclear and lymphocytic infiltration, complement deposition, human IgG deposition in animal models that have had antibody transferred to them, as well as astrocyte destruction, as shown in GFAP and aquaporin 4 staining, complement deposition, and finally, axonal loss and oligodendrocyte loss. When we examine histopathology in patients, we can see that the aquaporin 4 mediated NMOSD lesion has evidence of multiple different pathologies, but in particular is the classic pathology of inflammatory cell infiltrate, astrocyte loss, demyelination, and neuronal injury. There are other areas in which the inflammatory infiltrate is not as great. However, there is significant neural cell and glial cell destruction. These areas likely represent the transition from acute inflammation to chronic injury. However, there are additional regions without much inflammatory infiltrate, which show peculiarly morphologically changed astrocytes and no significant glial or neuronal destruction, suggesting non-lytic pathology that also occurs in NMOSD. So to explain all these pathologies, let's look a little bit more closely at the mechanisms that underlie CNS injury in NMOSD. First and foremost, there is antibody-mediated complement activity, or what we call complement-dependent cytotoxicity. Aquaporin 4 antibody binding to the astrocyte end-feet results in complement activation. And in animal models and antibodies that are mutated to lose their complement activity, or in animals treated with complement inhibitor, we see a direct abrogation of NMO aquaporin 4 mediated lesions. But antibody complement activation is not just pertinent for destruction, but is idealized in this NMO system to actively assemble antibodies onto arrays of aquaporin 4 on the cell surface, to drive accentuated complement activity, as shown both in vitro and in vivo. And with this, there is additional activation of immune components that, when added to models, show that there is complement-mediated degranulation with accentuated tissue destruction. For instance, in the bottom right, when eosinophils are added to an ex vivo tissue culture model, and accentuation of granulocytic activation and macrophage phagocytosis within the intact animal. In addition to complement, there is a process called antibody-dependent cell-mediated cytotoxicity, where antibody bound to astrocyte end-feet is engaged by the Fc receptor on polymorphonuclear cells, macrophages, and NK cells. In animal models, when this ability to engage the Fc receptor is disrupted, we see a significant reduction in the size of NMOSD animal lesions. And when this process alone is performed in the absence of complement, it is able to drive significant lesion formation, but interestingly, does not drive significant demyelination. A third process involves these non-lytic injuries that can occur in lesions. With the binding of aquaporin 4 antibody to aquaporin 4 on astrocytes, there is internalization of the receptor with its associated cell membrane protein components, such as the glutamate reuptake receptor, EAAT2. And in this process, with large installation of aquaporin 4 IgG into the animal cerebrospinal fluid, we can see internalization of aquaporin 4 and its glutamate receptor resulting in neurologic dysfunction in animals that can be reversed. In addition, we can see the activation of astrocytes with the secretion of complement components, which attract microglia, resulting in subsequent activation of these cells and neuronal injury. This has led in animal systems to the thought that reducing excitotoxicity from internalization of glutamate reuptake receptors, reducing microglial activation, and inhibiting complement-mediated signaling may be novel ways to treat acute lesions. In addition, there is unique axonal pathology in NMO lesions. This is the living mouse spinal cord with axons in fuchsia and astrocytes in green. And you will see as I start the video that there is rapid destruction of astrocytes with the presence of aquaporin 4, IgG, and complement, and subsequent formation of axonal excrescences within these axons. These axonal excrescences are novel accumulations of beta-tubulin within axons and are a unique histopathology to NMOSD. Interestingly, these excrescences can be limited by treatment with mannitol and tetrodotoxin, indicating a role for water channel function and sodium channel ion conduction in their formation. So now let's turn to how we're going to treat NMOSD patients based on what we've seen as those factors driving histopathology. And when it comes to acute lesion treatment, we as neurologists, when we deal with neuroinflammatory conditions, constantly focus on the use of corticosteroids at high dose for preventing a complete lesional injury and or facilitating recovery. This leads to what I would call the steroid reflex. In general, there's a stimulus, which is demyelination that's acute, treatment with steroids at high dose, a gram a day, generally IV, although oral can be administered, and an expected response. Unfortunately, like many things in neurology, there can be clonus that develops, and then this process can be repeated over and over again. What do we appreciate about the use of high-dose steroids in the treatment of acute NMOSD relapses? We see that in a nice compendium of over 800 NMOSD attacks accumulated from the NEMOS network in the European Union and Germany, we can see that there is, in general, a small amount of patients that have complete recovery with treatment with acute steroids. And with subsequent rounds of treatment, often which in this study were predominantly driven by additional rounds of steroids, there was no further improvement in the amount of patients having complete recovery. This is repeated in another study on the right by Demuth and colleagues, showing that, again, a small fraction, roughly 10% of patients, return to baseline with acute high-dose IV solumedrol therapy for their NMOSD relapses. And while there is a 50% chance of some improvement, one step in EDSS for those with a modest disability at the nadir of their attack, those measured by 2 steps with a more prominent disability, the amount of patients improving to their baseline is limited, and there are 2 components that need to be met: a reasonable time to therapy. As is shown in this study, the mean time to treatment was unfortunately 14 days, and as I showed you in prior studies, time to treatment is critical. Of note, in this Demuth study, there was no complete recovery or good response to the use of intravenous immunoglobulin, although the number of patients treated was limited. When we look at optic neuritis in NMOSD, it appears that high-dose solumedrol can have a role if it's given in a timely fashion. This chart shows that the severity of vision loss is an important factor in the chance of recovery of full vision. But when we look at NMOSD, as shown in this top bracket on the right, and the timing of steroid administration, you can see that those patients that had a good recovery versus those that had a significant loss of recovery were generally treated within 3 days with high-dose IV solumedrol. In other conditions, such as MOGAD optic neuritis or MS optic neuritis, the timing of administration had more flexibility, with up to 7 days having a beneficial effect for MOGAD, and there was no timing that related to improved visual recovery when it came to MS or idiopathic optic neuritis. So in general, for an acute attack of optic neuritis in NMOSD, milder vision loss is, of course, a better chance for recovery, and administering steroid therapy as quickly as possible, less than 3 days, has a higher probability of improved visual outcome. What about other means of treatment? Plasma exchange is generally called for in the acute treatment of NMOSD relapses. While blinded and randomized clinical trials have not been performed, in retrospective studies comparing those NMOSD patients getting plasma exchange versus those getting corticosteroids alone, for optic neuritis, as seen on the left, there was improvement for those getting plasma exchange in their end visual acuity score, their mean deviation on visual fields, and the amount of nerve fiber layer loss on optical coherence tomography. For those receiving plasma exchange for motor lesions, as shown on the right, there was a significant improvement in another series relating to motor improvement back to baseline for those who got plasma exchange versus those who got corticosteroids alone. For both of these acute attacks, whether it's motor or vision, the time to plasma exchange, just like the steroid treatment time, is critical, with a greater delay to plasma exchange showing a fewer fraction of patients who can reach back to baseline recovery. What are new potential treatment strategies for NMOSD? As mentioned, as we looked hard at what drives lesional pathology, we can think that small molecule complement antagonists or the use of currently approved anti-complement antibodies would be an interesting strategy to limit lesional injury. When it comes to complement-mediated degranulation of invading polymorphonuclear cells or macrophages, antihistamines at high doses or chromalin sodium have been shown in animal models to limit lesional injury and or to limit lesion size in ex vivo slice culture assays. Inhibitors directly of degranulation with antibody-dependent cell-mediated cytotoxicity with neutrophil elastase inhibitors have been shown to be beneficial in animal models, and limitations to excitotoxicity or microglial activation could offer other approaches to limiting non-lytic pathology, as seen in additional animal models that I showed you previously. Other attempts to modulate osmolar and ionic balance could limit neuronal changes that are seen dynamically in NMO lesions, as I showed you several slides before. So now that we've looked at acute therapies, let's turn our focus to the chronic treatment of NMOSD, that is the prevention of relapses. Currently, we have 5 approved therapies for the treatment of NMOSD worldwide. 4 of these therapies are approved in the United States. Rituximab has its only approval in Japan. Of these 4 therapies, what I want you to concentrate on in this table in front of you is that all of these therapies have significant ability to reduce the risk of relapses in NMOSD. And in the long-term extension of the clinical trials that were used to approve them, there is a substantial reduction in the annualized attack rate reported in treated patients. So in general, by choosing an approved therapy for prevention of relapse in an NMOSD patient, you basically can't go wrong with what you treat. Let's first look at those treatments that are C5 complement inhibitors, and this includes eculizumab and ravulizumab. These 2 monoclonal antibodies bind to the same epitope on complement C5. Ravulizumab has been mutated to have a longer elimination half-life through mutations inserted both in the framework portions of the FAB division of the molecule, as well as additional mutations in the FC portion to increase recycling and its effective half-life. This means that the dosing interval of ravulizumab is much longer than eculizumab, for ravulizumab maintenance therapy being instituted every 8 weeks, and for eculizumab every 2 weeks. Both of these antibodies, due to their targeting of the C5 complement protein, will inhibit membrane attack complex formation, and by inhibiting the production of C5, should reduce polymorphonuclear activation, complement-induced granulation, and the effects of active complement components on the blood-brain barrier. However, because they don't act proximally for the production of early complement C3b, opsonization, and additional immune functions that deal with activation of early complement components will not be inhibited. Eculizumab and ravulizumab were approved for NMOSD treatment through the PREVENT and the CHAMPION NMOSD clinical trials. In the PREVENT trial, eculizumab is compared to placebo-controlled in a randomized clinical trial where patients could have been on monotherapy with eculizumab or received supportive immunosuppressive therapy throughout the clinical randomized control period. PREVENT had an open label extension where all patients received intravenous Soliris, which was administered initially with a loading dose for 4 doses, followed by an initial maintenance dose 1 week later, and maintenance doses every 2 weeks afterwards. In the CHAMPION NMOSD trial, this was an open label trial in which ravulizumab was compared to the historical placebo group from the PREVENT trial. In the long-term clinical extension, all patients continued to receive ravulizumab, and safety and efficacy were followed. For ravulizumab, the loading dose is twice every 2 weeks, followed by a maintenance dose thereafter for every 8 weeks. In this clinical trial for CHAMPION NMOSD and the previous PREVENT NMOSD trial, there was a substantial reduction in relapse risk for patients treated with C5 complement inhibitors, 94% risk reduction in the PREVENT trial using eculizumab, and 98% risk reduction for those receiving ravulizumab in the CHAMPION NMOSD trial, as shown in these Kaplan-Meier plots on the left. As you can see on the right, however, treatment with complement C5 inhibitors comes with a serious risk for meningococcal infections. We'll go over this later in more detail, but it is imperative that all patients being placed on anti-complement inhibitor therapy receive meningococcal vaccination at least 2 weeks prior to the onset of treatment with medications, unless antibiotic prophylaxis is going to be administered. The US CDC advises both the tetravalent and meningococcus B vaccinations to be administered initially, then roughly 4 to 8 weeks later as a booster, and then followed with an additional meningococcus B booster at 1 year, and then every 2 to 3 years later with boosters of the tetravalent vaccine every 5 years. There now is a combination vaccination available, which includes both the tetravalent and the meningococcus B vaccine together, and this has to be given in 2 doses 6 months apart, with an additional serotype-specific Men-B booster matching the type in the pentavalent vaccine at 1 year and every 2 to 3 years later. In addition to this pertinent risk factor for meningococcal infection, the most common treatment-related adverse events in complement treatment trials have been upper respiratory infection, headache, urinary tract infection, and nausea. B-cell dysregulation plays a central role in NMOSD. Currently, the anti-CD19 B-cell inhibitor therapy inebilizumab is approved in the United States and worldwide. Rituximab, an anti-CD20 B-cell inhibitor, is approved in Japan and is used off-label in the United States. B-cells contribute to NMOSD pathology by their inhibition of the presence of antibody-secreting cells, which are producing the pathogenic aquaporin 4 IgG, their role in germinal center activity to induce pro-inflammatory T-cell function, and to generate new clones of anti-aquaporin 4 producing antibody-producing cells. And in both the germinal center as well as in the central nervous system, pro-inflammatory functions of B cells, their secretion of IL-17, IL-6, GM-CSF, and tumor necrosis factor and lymphotoxin can exacerbate the pro-inflammatory nature of other immune cells, and B cells can be important for regulatory function, where diminished B regulatory function has been noticed in B regulatory cells in NMOSD, and their increased presence as a proportion of the repertoire in B-cell depleted patients may play a role in stemming inflammatory activity in affected individuals. When it comes to antibody-producing cells, CD19 can extend further into the B-cell repertoire and therefore may have an advantage over anti-CD20 directed therapies. In the germinal center, CD19 therapies may have a modulatory effect on B-cell development and extend deeper into the B-cell repertoire, therefore having an improved therapeutic effect over anti-CD20. When it comes to pro-inflammatory cytokine prevention, these two targeted B-cell depleting molecules are roughly equal, and there is potentially an improved regulatory role for anti-CD19, as improved depletion into the repertoire may allow for a greater proportion of naive and transitional B cells over time in the reconstituting repertoire. When it comes to B-cell depletion in aquaporin 4 positive NMOSD, the inebilizumab and Momentum trial, which included 231 patients, showed a significant reduction in the risk of NMO relapses, as shown in the Kaplan-Meier plot on the left. In this trial, the 6-month randomized control period was aquaporin 4 patients and non-aquaporin 4 patients who received medication of inebilizumab versus those on true placebo control. In the rituximab RIN1 trial performed in Japan, where there was weight-based dosing of rituximab versus a placebo control once again, NMOSD patients were enrolled after being clinically stable on corticosteroids. They were roughly 2 years on average after their last attack versus those who were enrolled in the inebilizumab trial on the left had enrollment within 1 year of their last clinical attack, or those who had 2 attacks over the past 2 years. Again, in the RIN1 trial, the frequency of those patients having a subsequent attack was measured, with no patients on rituximab having an attack versus 38% of those with placebo. B-cell depletion and treatment-related adverse events are very similar between anti-CD19 and anti-CD20s as shown in their clinical trial, with a similar frequency of patients in both clinical trials having treatment-related adverse events compared to the active placebo of prednisone in the RIN1 trial or placebo in the inebilizumab and momentum trial. Urinary tract infections, arthralgias, nasopharyngitis, and headache were some of the more common reported events. B-cell depletion has a particular risk for hypogammaglobulinemia, and in rituximab-treated patients versus inebilizumab-treated patients, the majority of these patients do not get hypogammaglobulinemia. The graph on the right for the inebilizumab trial through the open label extension period of 4 years, as indicated by the arrow relative to the rituximab graph on the left, show very similar levels of hypogammaglobulinemia. However, the inebilizumab patients may get to a faster rate sooner, and the amount of patients with severe hypogammaglobulinemia were similar between these conditions, with roughly only 5% of patients having severe hypogammaglobulinemia. Interleukin-6 plays a role in NMOSD pathophysiology, and the subcutaneous interleukin-6 receptor inhibitor satralizumab is approved for NMOSD therapy. Elevated IL-6 levels are seen in the cerebrospinal fluid of NMOSD patients and correlate with measures of disability and lesion size. Interleukin-6 stimulates the differentiation and the survival of antibody-producing cells, and interleukin-6 stimulates the pro-inflammatory differentiation of T cells into IL-17 producing T cells. Interleukin-6 signaling can be involved at multiple stages in NMOSD pathophysiology, at the level of inflammation in the differentiation of both naive and memory T cells into Th17 pro-inflammatory T cells, and prevent the differentiation of naive T cells into T regulatory cells. In the germinal center, IL-6 is important for T follicular cell differentiation, and therefore is important in the differentiation of B cells and their supporting survival of differentiated antibody-producing cells. At the blood-brain barrier, interleukin-6 produced by microglia and astrocytes can enhance blood-brain barrier permeability and immune cell migration, and within the central nervous system, IL-6 produced again by astrocytes and microglia can facilitate demyelination, axonal, and oligodendrocyte injury. In its clinical trials, satralizumab in the Secure Sky trial, which had background immunosuppressant therapy allowable, and the Secure Sky Star study, where satralizumab was compared to placebo, there was 79 and 74% reduction in aquaporin-4 seropositive patients treated with interleukin-6 inhibitors. These therapies were generally safe with no increased risk for infections over time. Adverse events included nasopharyngitis, as well as injection site reactions that were most common. And with regard to screening for abnormalities, liver function tests, lipid panel abnormalities, and blood counts did not show significant differences between the placebo and active treatment groups. So how are you going to think about using these treatments in NMOSD patients? One could think about the first attack and whether this attack was treated rapidly and how are we going to prevent subsequent attacks. And some of that is going to depend on both the time that you have to engage in therapy and the access to various therapies. But also there's an attack that happens while someone has already been treated on therapy, perhaps an unregistered therapy. This is an example of such a case in which a 30-year-old woman placed on azathioprine after her first attack of NMOSD optic neuritis is wondering whether she should stay on unapproved therapy or move to a registered therapy. And what this is indicating is, unfortunately, we have no markers to tell us whether the patient is being effectively treated or not until they have their next attack. What I want to point out is the unregistered therapy, the oral immunosuppressants that are commonly used, have been evaluated in cross-sectional studies looking at estimated attack frequencies before treatment and after treatment. And the annualized attack rate on treatment, interestingly, are very comparable to the placebo groups used in our baseline registered clinical trials. So this could give you some idea that compared to what we see with our registered therapies, which are an order of 10-fold greater magnitude in reduction of relapse rates, might indicate that unless someone has been stable for a long time, there is significant added benefit for potential registered therapies versus off-label therapies for the prevention of relapse in this condition. What about that first attack? What therapies might you think of doing? In this case, this is a 26-year-old woman who's had a new case of optic neuritis, and she was placed on inebilizumab, anti-CD19 B-cell depleting therapy. However, soon after her placement on treatment, she had a new attack of optic neuritis. What should we do? Should we switch therapies as this is a failure? Well, we kept going on her inebilizumab therapy, and she's been stable without further attacks for 3 years. And so what I want to bring up is, after a first attack, the presence of a second attack should be considered with the timing of how attacks were initiated. In both the NMO and Momentum treatment trial for inebilizumab and the Secura Sky and Star trials for interleukin-6 receptor inhibitor therapy, those patients who had early attacks did not tend to have a higher risk for later attacks, with the attack frequency going down successfully over time. Roughly 80% of the patients participating in both trials did not have subsequent attacks when they had an early attack on the trial. What about this young woman who had bilateral optic neuritis and transverse myelitis attacks, who was treated with rituximab for several years, with relapses occurring multiple times over a treatment despite an effective CD19 count of 0? Should we switch therapies given the frequency of her attacks over a long period of time? The answer is certainly yes. And in this case, we switched her to inebilizumab due to her preference for a low frequency of intravenous therapies given small veins and difficult access. She had no further attacks for 4 years, again indicating that CD19 may not be the same as CD20 depleting B-cell therapies. But when it comes to switching, you should think, Do we switch off-label to registered therapies, anti-CD20 to anti-CD19, between interleukin-6 receptor inhibitors and B-cell depleting therapies, or between complement inhibitors and either of those two therapies? And what I'll say is the decision has to be made on a case-by-case basis based on prior treatments, comorbidities, and access to therapy. Switching therapy for NMOSD activity can go in any of these directions, but I would implore you to overlap therapies in any direction and to use high-dose oral prednisone to bridge that therapy from one agent to the next in order to provide additional coverage during times of disease activity. With regard to side effects and adverse events, one can consider adjusting the dosage of therapy, adding additional treatments, or switching between therapies once again. Here is an example of a woman who had transverse myelitis, was treated with inebilizumab, carbamazepine, and sulfamethoxazole trimethoprim for urinary tract infections and spinal cord spasms. She unfortunately developed leukopenia right away, but we didn't switch her medicines, but adjusted her comorbid medications in order to limit her risk for leukopenia, switching her carbamazepine to lacosamide, and discontinuing her antibiotic. This resuscitated her white blood cell counts. However, a year later, she developed hypogammaglobulinemia. Instead of switching her therapy again, we instituted IVIG. However, soon afterwards, she developed infections despite her IVIG therapy, and therefore we ultimately switched her once again to a complement inhibitor therapy, and she's had no further side effects or attacks of her disease. In this case, a 55-year-old woman with NMOSD optic neuritis was treated with rituximab and developed infusion-related reactions of myalgias and migraines. She was switched, in this case, to concurrent oral prednisone therapy to try to reduce these inflammatory side effects, but without success, we moved her forward to satralizumab, but unfortunately, she developed her migraines once again, and therefore we returned to B-cell therapy, but this time in inebilizumab in order to limit potential anti-chimeric antibody inflammatory reactivity, and she had excellent infusion tolerance and control of her migraines for the subsequent 2 years. So switching therapies for side effects and tolerance, there's no need to immediately overlap therapies. This could be done in a reasonable fashion based on the switching program and the reason for side effects management. But in either of these cases, you can be very flexible in how you do this based on the length of control. I try to base this on the half-life of the therapies. Some special circumstances to cover for eculizumab and ravulizumab. Meningitis prevention should be performed with active vaccination before therapy begins, at least 2 weeks prior to administration, and if not, prophylactic antibodies should be provided. There is currently recommendation for additional vaccinations against Haemophilus influenzae and Streptococcus in patients receiving C5 complement inhibitors in the US, but you should follow the recommendations of your national guidelines for wherever you are around the world. Antibiotic prophylaxis should be considered for patients until their vaccine regimen is complete, but this is still uncertain where this could result in significant antibiotic treatment for up to several months under some vaccination protocols. What I want to come back to here is that B-cell depleting therapies can influence vaccine response. As shown in the Bar-Or-Valache study, we're in the middle of B-cell depleting therapy with ocrelizumab. Patients were given a variety of vaccinations. I want to point out that the pneumococcal vaccination, a vaccine against an agent experienced during life, had very limited effect with B-cell depleting therapy. However, those for a novel vaccine, keyhole limpet antigen, had a substantial reduction in vaccine response. This is important as we consider meningococcus vaccinations when it comes to C5 complement inhibitor therapy. And when it comes to data that we have in hand from the CHAMPION trial, 84% of those patients who received prior B-cell depleting therapy before enrollment in this trial received their vaccination more than 3 months after their last rituximab dosage. Of those patients who were in the trial, one patient who had prior B-cell depleting therapy had a case of meningococcus. They were vaccinated 1.5 years prior to their B-cell depleting therapy and had a booster during the trial. They had a meningococcal B infection, but were not vaccinated prior to the trial with meningococcal B vaccine. There was no B-cell depleting therapy in another patient who had tetravalent serotype meningococcal infection. So other special treatment considerations for patients with fragile diabetes, C5 inhibitor therapy and IL-6 inhibitor therapy require no concurrent steroid as co-medication. That could limit steroid effects on blood sugar control. Those with viral infection or tuberculosis should avoid B-cell depleting therapy unless they are given antiviral control or interleukin-6 receptor inhibitor therapy, particularly both for tuberculosis. And for pregnancy, C5 inhibitor therapy has a historical record of use in pregnancy. B-cell depleting therapy may be timed to avoid direct exposure to the fetus based on the timing of administration. So for antibiotic prophylaxis for those on C5 inhibitor therapy, for those that need acute therapy with C5 inhibitor, consider IV ceftriaxone in the hospital, followed by preventative doses with oral azithromycin and or rifampin. For those with acute transition due to attack, IV ceftriaxone again with azithromycin as an oral prophylactic, or for those patients on C5 inhibitor with early signs of meningitis, having them have azithromycin at home to take would be prudent, and or the administration of a third-generation cephalosporin in the hospital setting as soon as possible. I've produced a pocket guide to summarize the currently approved and a portion of off-label therapies available for the treatment of NMOSD patients. What I've tried to just briefly compile is what is the target of these therapies, the route of administration, their basic dosing regimen, albeit for anti-CD20 B cells, quite variable in the literature, and the clinical trial data when relevant, and the common adverse events associated with each of these therapies. Of note at the bottom is a little information regarding special issues and laboratories related to treatment with each of these therapies, in particular reminding you about the vaccination needs for patients on complement C5 inhibitor therapies, the monitoring needed for patients on satralizumab and inebilizumab and rituximab, as well as other issues related to the use of oral immunosuppressants and their monitoring. I hope you find it useful as a quick reference. So the treatment of NMOSD is both an art and science. There are 4 approved therapies with oral immunosuppressants and biosimilars available. There are treatment responses that need to be evaluated as patients proceed on therapy. What was their prior relapse status? What is their current relapse status on therapy? What's the duration of treatment they've had to date? And what is their vaccination status? How are they doing on therapy? Are their adverse events treatment related or administration related? And what are the physical, social, and financial circumstances driving treatment access? So I'd like to thank you for your attention, and I'm now here to answer some questions for the general audience.
Jeff, thank you very much for that excellent
Yeah.
review of this important topic. It's obviously a lot of information to cover, but thank you very much for doing so. We have a few questions that have come in, and we'd like to briefly address those, Jeff, if possible. So why don't we go to the questions? So first question for Dr. Bennett is, when do you consider bridging therapies in NMOSD?
I consider bridging therapies to be the treatment with prednisone during the time between attacks and the institution of their first therapy or a new therapy from which a patient is switching. And I think it's very important to consider this bridging therapy with prednisone because, as we have observed in both the NMOMentum trial for inebilizumab and the SECURE-SKY and SECURE-STAR trials for satralizumab, there is a period of time and within the first few months that patients appear to have a higher risk for relapse than we've observed in the long-term extension period. And therefore, a prolonged bridge with a taper of steroids I find to be beneficial as I'm waiting for these new medications to take effect.
Thank you very much, Jeff. Another question. When you're thinking about bridging or moving from one treatment to another, talk a little bit about combining treatments and the potential overlap during those times.
Well, I think in terms of biologic therapies that we currently have approved for disease, we have no data with regard to additional benefits or additional risks, importantly, when we combine any of the biologic therapies. That is a complement inhibitor and B-cell depleting therapy, or an interleukin-6 inhibitor and B-cell depleting therapy, or vice versa. But we do have some data with regard to immunosuppressants and combination with interleukin-6 receptor inhibitor therapy in the SECURE-SKY study, as well as with complement inhibitor in the eculizumab and ravulizumab trials, the PREVENT trials, and the CHAMPION NMOSD trials. In these trials, there appeared to be an additional benefit for those failing these immunosuppressants with the addition of the respective biologic therapies, and there appeared to be no significant increase in adverse events with regard to the immunosuppressant arm alone in the PREVENT trial and with the immunosuppressant arm alone when it comes to the SECURE-SKY trial. So I think in those cases, we can combine therapy and with improved treatment response, consider reducing those therapies as indicated by that response of the individual patient. But for biologic therapies, the jury is still out.
Thank you very much, Jeff. A next question. What would you say is the major therapeutic gap for NMOSD treatment at the present time?
Well, I think one of the major therapeutic gaps is a defined evaluation of our acute therapeutic armamentarium. How well are patients in a blinded, controlled study doing with high-dose steroids, plasma exchange, and potential novel therapeutics? How can and how should we engage in those therapies with consideration for the timing since the onset of relapse? And since, as I mentioned early in this talk, that a substantial portion of the patient's disability is accounted for by their first relapse, it's important to have optimal acute therapeutics. The other major therapeutic gap is potentially intolerance. That is, can we use the C word, that is, cure NMOSD patients by tolerizing them against aquaporin 4? And that's where our next major and perhaps permanent breakthroughs could arise, either through cell-mediated therapies, as has already begun for anti-CD19 directed CAR T cells, or for more focused therapeutics that are directed at tolerizing against the autoimmunity against aquaporin 4.
Right, Jeff, there's a lot going on in those areas. One other question has to do with the rationale for selecting a preventative therapy in NMOSD and how to sort of prioritize decision-making.
That's always tough, and I think what is most important is not arbitrarily deciding for your patient, but engaging with the patient with the variety of options that are available. Is there infusion access for this patient, or should they be going to a subcutaneous preparation? Do they have the ability to travel to an infusion center, or is there home infusion capabilities available for them? How does the frequency of administration affect this patient? And their financial needs may have a significant impact with regard to whether their insurance, particularly in the US, is covered by pharmacy or medical benefits. And in particular, I think it's important for us to remember that there is goals that the patients have as individuals. What is that patient's goals in the future, and how could therapy and the effectiveness of that therapy impact the patient's ability to meet those goals based on efficacy, frequency of administration, and potential side effects?
Yeah, great points, Jeff. And I think there's one last question that relates to looking, in a forward sense to the future of preventative treatments for NMOSD. And I think you touched on it, but maybe you could just say a few more words about it.
I think we touched on the huge impact potentially of tolerization, but I think for future preventative treatments, we have the aspect of, again, CAR T therapies directed against B cells that might be particularly useful for attacking inflammation that may be within the central nervous system in NMOSD patients and deeper within the autoimmune repertoire within the bone marrow of these patients, as well as preventive treatments that might target new agents and cell populations that play a role, particularly microglia within the central nervous system and members of the innate immune system that may drive additional NMOSD pathology.
Well, certainly exciting times given the approved therapies and the promise for potentially new therapies that target the fundamental basis of the autoimmune problem. Jeff, thank you very much for those insights.
Thank you for allowing me to speak, and I appreciate the opportunity to talk to everyone.
Well, we really appreciate Dr. Bennett's excellent presentation and great information. We'd like to remind everybody that the presentation is eligible for CME activity. Please visit the GJCF Education Center. You can use the QR code shown on the right. Select the session you're interested in, register for that session, view it, and fulfill the CME requirements to receive CME certification. We greatly appreciate Dr. Bennett's presentation today, and we remind everyone that this series is ongoing, and the next series will be presented by Dr. Zamville, focused on immunologic mechanisms and biomarkers. And please note that the prior sessions are also available online using the QR code shown on the left. All of this information can be accessed through the Guthy-Jackson Charitable Foundation website and its education center. Once again, the link is shown here, and the QR code can be used to access this center. Lastly, we greatly appreciate the support from Alexion and AstraZeneca Rare Disease section, which is sponsoring the NMOSD Grand Rounds series produced by the Guthy-Jackson Charitable Foundation.